So for this first case, the patient is a 40-year-old gentleman who was previously treated with a VP shunt for what was thought to be post-infectious hydrocephalus. They thought that he'd had maybe a fungal meningitis because the pathogen was never found. But he was eventually shunted with a normal CSF profile, and then came in several months later with lower extremity paresthesia, urinary retention, and said that his legs just felt weak. On physical exam, grossly normal motor exam without any obvious motor deficits, no sensory deficits, but he did have hyperreflexia throughout, as well as clonus. So, Sumed, what imaging would be helpful just based on this patient's presentation?
Based on the patient's presentation, I would likely go to imaging of the spine, particularly cervical, thoracic spine, just given that hyperreflexia. I think it's important to image the spinal cord itself. I guess, you're saying that he's 5 out of 5 strength in the lower extremity, so I'm not necessarily as concerned maybe about the lumbar spine necessarily, but if there was nothing on cervical and thoracic, I may as well get like the lumbar imaging as well. And I'm not as concerned for like a hydrocephalic picture, given that he's awake, alert. It doesn't seem, I guess, like lethargic or toxic appearing despite having that shunt. So cervical MRI and thoracic MRI first.
Yeah, that's a good thought. So, and I should mention he had a CT when he came to the ER, obviously, because he has a history of a shunt, and that's what they do, and that was normal. They did end up doing kind of full neuro imaging like you recommended, but given the urinary retention, they actually started, or we're going to start rather with the MRI of the lumbar spine. So, can you talk about what we see here?
Yeah, on the MRI lumbar spine, looking at the sagittal T2 right there, it looks like that there's a significant amount. Looks like there's like a posterior fluid collection, or maybe even like the spinal cord, the spinal nerve seem almost tethered anteriorly, kind of at the L1-2 area. So it's like a little bit of, yeah, it seems like there's a significant amount of tethering there.
And then looking on the axials on the right, does that look abnormal?
It does. I mean, it looks like everything is being kind of I guess eccentric more towards the left.
Right. So
right, supposed to be right in the middle.
Do you think that this is an intradural or extradural process?
This looks like it's an intradural process.
Yeah. Good. You'd be right. Yeah. So, we would say there's enhancement of the distal spinal cord, the meninges, and then, as you said, there's this intradural inflammation and these intradural cysts that are causing compression of the nerve roots. Is there any additional testing that you would do aside from imaging, like we talked about, just based on this?
Yeah, based on this, I would also kind of get inflammatory markers, ESR, CRP, just basic preoperative lab workup for him. See a PVR, I would also try to get just to see what his retention is.
Good.
I guess I would start first.
Right. And then do you have any thoughts about, if you start thinking about differential, like what types of conditions could present this way, just based on the imaging? Like, would you say that you think that this is a neoplastic process, or you think it's infectious or inflammatory?
I feel like it's an infectious inflammatory process as opposed to a neoplastic process. The gentleman doesn't seem to have, I guess, any evidence of like direct masses. He has these cysts there with a history of a post-infectious hydrocephalic process. So I would say probably infectious or inflammatory first as opposed to a neoplastic process.
Yeah, good. So you mentioned testing some serum inflammatory markers. You could also think about testing CSF. And differential, we've kind of covered. We think it's probably a infectious or inflammatory process. Given that there's multiple lesions, you could think about metastasis, but intradural metastasis, and especially multiple intradural metastasis, would be really rare and wouldn't explain all the leptomeningeal enhancement that we see all the way up. And then in terms of surgery, would you offer surgery to this patient? Do you think that there's anything indicated on our part?
Yeah, he has, he has 5 out of 5 strength, but he is hyperreflexic and has definite, at least kind of this these multiple cysts in the intradural space. I don't know, I guess I'd be personally inclined to offer surgery, mainly the goal being to help untether the core, to help decompress those cystic portions of the spinal canal intradurally, and then yeah, that I would offer, I guess, laminectomy to try to get to the major cysts that are pushing that cord eccentrically to the spinal roots eccentric to the left, and then decompress that. Just because he is symptomatic and he is hyperreflexic.
Yeah,
and has attention.
So the most important thing in this patient is going to be to try to get a diagnosis.
Yeah.
He's got a lot of symptoms, and there's not any individual surgery we can do that's going to fix all of them. But I agree. I mean, if possible, to decompress some of the cysts, then that would be good too. But the main thing here is that we need a tissue diagnosis, and so that's what was done: a focal laminectomy with aspiration of the intradural abscess.
Just a couple of comments before we show the pathology. I mean, actually, neurology consulted us because they wanted us to do a spinal tap. They couldn't get it and said, well, let's send it to neurosurgery to do a lumbar puncture. And again, we looked at it, had the same feeling, diagnosis would be the most important. Although he had some cysts that were pressing, the cauda equina, and had some urinary symptoms. And we targeted one of the biggest cysts that looked like it had some soft tissue associated with it. If you look at the imaging carefully and sort of drained the cyst, took some of that soft tissue in one of the cysts and sent it to pathology.
I guess needless to say, intraoperatively, you probably try not to puncture the cyst or drain it in such a way that it's not going to disseminate into the CSF, because since it may be infectious. Is that how you guys approach that? Or
I mean, ideally in the brain, when you have an idea of what it is preoperatively, yes, but here, we had no idea what it was going to be, and it's just a mesh of inflammation and stuff, and we were just pretty excited to be able to get some soft tissue rather than just arachnoid.
Right. I see. Yeah, I understand that. It was kind of a surprise diagnosis. So what you're looking at here is the soft tissue that Dr. Levy was talking about is the dark pink or fuchsia colored elements in the top and on the right side of the slide. Those are, I guess, a mixture of fibrous tissue, fibrin, and inflammatory reaction to the central area where you're looking at a parasite. Anybody willing to guess what we're looking at here from a distance? This is not an uncommon diagnosis. Everybody's muted, so I guess nobody has an answer, or people know already. Let's go to the next slide. So here you see the close-up of the cyst wall of the parasite. You can see there's a reticular layer in the center. There's a cellular germinal layer which has cells, and there is a cuticular layer at the top, this very dark eosinophilic substance, and there's some hair-like processes, from that cuticular layer. Next, please. So this is a trichrome stain, which shows what I just told you, in a more colorful way: reticular layer, cellular layer, and cuticular layer of the cyst. So we don't see the scolex here in this particular slide. There is some parts of the cyst that was calcified, and that was the surrounding reaction. So we're looking at cysticercosis. That's the diagnosis in this case. This is a PAS stain that shows, some of the details of it, but I'm not going to go through it again. So let's go for the discussion.
Yeah, so just a quick review on cysticercosis. So obviously in medical school, we all kind of learn about the life cycle, but it comes from undercooked pork, is the gist of it. And then the parasite goes through one life cycle and then is passed in the stool to another person, where it goes through the second life cycle, which can then go on to invade muscle, but really anywhere in the body. And kind of the most typical presentation or within the CNS is like the MRI that's shown on the right. Usually with calcifications, you have these multiple kind of loculated cysts. Like Dr. Gultekin mentioned, it's actually a very common disease, and this is a map from the World Health Organization. But basically, all around the world, on 6 continents, it's prevalent and endemic in many populous countries. Just some key points about neurocysticercosis, meaning when it's involved the CNS. Most people are actually asymptomatic, and that's true of people who are infected with cysticercosis in general. Most people don't develop symptoms, and even those with neurocysticercosis, the natural history is not to become symptomatic in most patients. The brain essentially walls off those cysts, and they'll eventually die and go away. And then all that's left behind usually are some areas of calcification. For the disease to spread into the CNS requires a really heavy systemic burden because of the blood-brain barrier. And it is a significant cause of epilepsy in areas where it's endemic. And in some places, about a third of epilepsy is attributed to neurocysticercosis. And hydrocephalus is also a common presentation when people do become symptomatic. Neurocysticercosis is diagnosed with antibody detection. There's specific antibodies that can be used essentially to check the serum for CNS infection, and then treatments with praziquantel and or niclosamide. And with respect to spinal involvement, like this patient had, it's rare, but there's a good number of case reports that describe it. One group actually made the observation that more than half the time when the basal cisterns have cysts in them, there's also spinal involvement. So people think that it spreads to the spine. It has to get into the spine by first spreading into the brain. Okay.
Hey, Josh, can I ask you a quick question?
Sure.
This is Evan. I just want, because we took care of him when he initially presented with like basilar meningitis, but
right.
everyone suspected that this was a fungal meningitis because of the way his imaging looked, and there was no evidence of cysts in the brain, this to give us any suspicion. And in fact, he kind of presented with almost a pseudotumor-like picture where he had elevated ICPs and he was going blind. So I just wonder, did you see anything in the literature about that with people who have neurocysticercosis and then develop like a fungal or a basilar meningitis?
Yeah, definitely. There's actually in young women in endemic countries, pseudotumor. They're commonly diagnosed with pseudotumor actually when they have kind of an early neurocysticercosis infection. So yeah, that's definitely something that happens. You kind of get this elevated ICP pseudotumor presentation, and then it later turns out that this is what it was. Less common in a kind of a middle-aged male like this patient was, but yeah, definitely.
Thanks, man.
Yeah, we had a discussion with the team about what was the best place to biopsy. I mean, there was really no intracranial areas that you could target, and so that's why we decided to do the spine. The other issue was that this guy, I guess, I don't know, he had a travel history. I think he came from either Central America or Mexico and had been sort of traveling recently from another country. I don't remember the details, but that was, I guess, another clue to being possibly cryptococcosis.
Definitely, yeah, very, very interesting case. Okay, on to case 2. So this case is a 16-year-old girl with a history of NF1. She previously had a resection of a neurosheath tumor from the infratemporal fossa by one of our ENT surgeons, and she comes into clinic with left-sided cheek pain. On exam, she's got diminished sensation and in the left V2 and V3 distributions. Otherwise, unremarkable exam. MRI was done. Eva, can you describe what you see here?
Yeah, sorry. So yeah, it's a homogeneous contrast enhancing lesion that's looks like it's lateral to the cavernous sinus. It looks like that it's do you have a T2 just so we can differentiate if it's intracavernous versus extracavernous?
Good question. I don't have a T2, but it is extracavernous.
Okay, so yeah, it looks like it's an extracavernous lesion. Yeah, I guess differential could be maybe. Actually, I guess it looks like it's kind of tracking into the Meckel's cave region as well, and so it could be a meningioma, the lateral sinus or the lateral sinus wall, or it could be like maybe a peripheral nerve sheath tumor, given it tracks along the nerve root.
Yeah, so good. It's definitely an enhancing mass in Meckel's cave, like you said. If you really look, you can see that it looks like it's probably tracking out foramen ovale down here. But yeah, lateral to the cavernous sinus, enhancing. Definitely looks like a nerve sheath tumor. Very good. Sorry, my computer's not clicking forward. 1 second.
Try closing and restarting.
Okay. Think we're good. All right. Yeah, and just to kind of review that, so we know that the patient had a tumor that was resected from the infratemporal fossa. We think that that tumor may be tracking out of foramen ovale. So just a kind of a reminder what those what that space entails. It's essentially behind the maxilla, underneath the temporal floor, and then in front of the styloid process and the ear canal. And you already covered some things in your differential. And I agree with you. I think nerve sheath tumor is a possibility, so is meningioma. And it could also be a malignant nerve sheath tumor, since we know that this is a reoperation. And then, Eva, do you have any thoughts on how you could access this tumor?
Can you go to the images again real quick?
Yeah.
So I guess for this, there's a few different ways that you could do it. You could do like an anterior clinoidectomy and dissect through the cucubu plane and come from the kind of from the front, and then or you could go subtemporally, or because it's extending outside of Meckel's cave, you could also do a retrosig and do a suprameatal approach to get to that that area that's in Meckel's cave. However, that's probably not as good of an approach because you'd have trouble getting the stuff that's more anterior and lateral to the door of the cavernous sinus. And so I think for this approach, the best would probably be the dissecting the Hakuba plane and coming down to get the tumor there.
Yeah, so the pathology is really centered in Meckel's cave, like you said, and you also mentioned kind of doing like a subtemporal type of approach. I think, you know, for something like this, they're able to avoid doing a lot of drilling because just you know, adequate retraction of the temporal lobe with a well-placed craniotomy should give you a good access to this type of tumor. For other kind of things to think about, you know, I think this picture on the top right illustrates really well what they did. So there's two layers of dura that cover the cavernous sinus, and if you kind of peel away this outer one, then that will unroof Meckel's cave, and that can be done through a subtemporal approach. That's what they did here. And then I think that these anatomic models are nice because they really give you a good idea what your operative kind of working corridor would be. So if you look, you've got V2 and V3, and then between those two is the anterolateral triangle. So drilling through that's going to put you in the sphenoid sinus, and then lateral to V3 here, and in front of the GSPN, that's the posterolateral triangle, and drilling into that puts you in the infratemporal fossa. If you imagine a line kind of straight back from the middle meningeal. So to follow this nerve down into the infratemporal fossa, if you were going to drill, you could drill some here. In this case, I don't think that they needed to. And I'll turn it over to Dr. Gultekin.
So they called me for a frozen section on this one because what they explained to me was that this person did have a history of previously diagnosed malignant peripheral nerve sheath tumor, and if this is also representative of MPNST, they may have to do a more extensive surgery, including perhaps some of the, I don't know, resection of jaw elements. I don't know what happened in the end, but when I looked at the slide, frozen slide, it was very obvious that this was nothing else but an MPNST. You're looking at very cellular malignant tumor here. Of course, it's not obvious that this is an MPNST from here, but given the history, it's very likely that it is. It doesn't immediately look like a meningioma or a carcinoma or a lymphoma or a melanoma. You know, in a 16-year-old with this history, the differential is very narrow. Next. So, by the way, before we go on, do you know what surgery, what was the surgical, material? What did they do? Did they do extensive resection of bone components or anything?
No, they didn't need to.
Okay.
They didn't need to take much bone. They really just opened the dura over Meckel's cave and then took all the tumor out that they could see.
All right. So, because I didn't receive any extensive resection material either. So this is also part of what I saw on the frozen necrosis. There are 3 light pink areas of necrosis here. And, this makes it easier, of course, for me to identify it as a high-grade malignancy. Next. So as Eva was implying, it is actually going through the cranial nerve elements probably, and this may be representative of that. You see here embedded in some fibrous tissue, some islands of what seems to be perhaps cranial nerve fascicles infiltrated by tumor. Next. And to verify, we do have a ganglion. You can see the ganglion cells with a very large nuclei, purplish cytoplasm, just like DRGs, dorsal root ganglia. You can see this is probably part of the 5th nerve, cranial nerve 5 ganglion, infiltrated by MPNST. S100 was weakly positive. Next. KI67 was very high, very aggressive looking. Next. And also it was positive, variably with peripheral nerve markers as SOX10, CD99, CD34, and supporting the peripheral nerve origin. Okay. And neurofibrosarcoma is a kind of an outdated term. We call it MPNST, as you know, but go ahead.
Right. So, it's certainly a rare tumor, but it is most common in NF1. Some of the literature cited as many as 10% of people with NF1 will end up with an MPNST. Can occur anywhere in the body, obviously not just intracranially. These tumors can also arise de novo. It's common for them to come from a tumor that's already been resected or been followed, but sometimes it is the initial diagnosis. Prognosis is poor if there's metastasis, and these are invariably treated with chemotherapy and radiation. As in this case, complete resection is the goal when a patient's diagnosed with one of these tumors. Okay. Our next case is a 39-year-old woman who has progressive worsening of vision and headaches over the past 2 months. She was referred by an ophthalmologist for retrobulbar vision loss. She has no past medical history. On physical exam, her mental status is normal. She doesn't have any motor deficits. She does have worse vision in her right eye, and she has papilledema in her left eye. Do I have Mike Cater? Are you online?
Yeah.
Cool. Does this physical exam make you think of any type of pathology, or maybe there's an eponym that would go with this presentation?
Possibly like Foster Kennedy.
Yeah, cool. So what kind of things can cause Foster Kennedy?
Could have medial sphenoid wing meningioma, nasal, or pseudotumor, or like a nasal or retrobulbar tumor.
Yeah, good. So yeah, it can really be caused by a lot of different things, but classically meningioma, olfactory meningioma. And Kater, what do we see here?
So there's a homogeneously enhancing lesion. Looks like maybe a tubercular meningioma, kind of like extends down into the sella maybe. It'd be, I guess, nice to see a CT to see if there's hyperostosis in one particular spot to sort of know where the meningioma grew from.
Yeah, good. Yeah, we covered differential. I agree. Most likely meningioma. It looks like there's kind of this dural tail of enhancement, kind of coursing along the planum. So that may be the origin, but it's kind of hard to say. So surgically, what approaches could you use to take out this tumor?
You could do a terional, come subfrontal. Probably you may want to extend your cranium down a little lower so you can look upwards, like an orthozygomatic approach. You could, it's kind of big. I guess you could technically do it endoscopically, but I don't think that size it's really feasible.
Good. Yeah. So endoscopic or terional would be your two possible approaches. And then goals of surgery, obviously, with it being a meningioma, is going to be for a gross total resection. And they actually did go endoscopic on this one.
So this was, we saw these islands of typical meningioma tissue on the left H&E slide. And there was no necrosis, but there were rare mitoses identified. That purplish slide with the green arrow shows a mitotic figure at the top right. And so Dr. Saad looked at this case, and the Ki-67 was sort of moderately elevated, up to 10%. He concluded that, if we see he saw like 2 or 3 mitoses in a small specimen along with the elevated Ki-67 index, he thought that this was an atypical or a meningioma with atypical features. Okay.
Yes. So just to review, because these come up on our board exams, we tend to think of grade 1, grade 2, and grade 3. Atypical is grade 2. There's a lot of different subtypes for grade 1. So I never try to memorize all those, but you can certainly memorize the 3 types of grade 2 and grade 3. In this case, as we said, it's a grade 2 atypical meningioma, and there's no consensus on how best to treat these tumors after surgery, whether radiation is appropriate up front or not. And if you look through the literature, there's actually a lot of conflicting reports on this. There's a good number of studies that have shown some improvement of progression-free survival with radiation. But there's also been several large-scale studies that have shown no overall benefit with complete resection beforehand again. And then people do agree that radiation is appropriate when there's an instance of tumor recurrence. Okay, and moving on to our last case. This case, we have a patient who's a 63-year-old man with 1 month history of progressive vision loss and headaches. Talking with the patient in the office, he remembers that he actually also lost his smell about 2 years ago, and that's before COVID. Physical exam, the patient's awake and alert. He's got no light perception in his right eye. Vision in the left eye is good, and otherwise no focal findings. And MRI and CT were done, and that's shown here. Vignesh, are you able to describe kind of what we're seeing here?
Yeah, for sure. So it looks like, at least on the CT scan, there is erosion of the anterior skull base to the floor of the anterior cranial fossa. On the MRI, he has a pretty homogeneously contrast-enhancing lesion sort of throughout the anterior skull base that invades into the posterior nasopharynx, as well as all the way up into the inferior frontal lobes. Based on this appearance, I would guess either a high, maybe one consideration would be like a high-grade meningioma or a sinonasal, like aggressive sinonasal carcinoma, possibly esthesioneuroblastoma, olfactory group meningioma. I guess he does have like erosion of the bone, so possibly esthesio given the erosion of the bone.
Yeah, excellent job. I would say that's a very good description. And the only other thing, I mean, he is blind in his right eye, and we can see on the MRI and CT, it looks like the disease is also eroded into the orbit. I think you hit everything on your differential. Certainly, esthesioblastoma, olfactory meningioma, or nasopharyngeal cancer would all be considerations there. Some other kind of strange things you could consider, if it were a young man, then J&A would be something else to consider. Just for a tumor in this area that enhances, but I agree that it would still even be lowered down just based how it looks on imaging. So what would the goals of surgery be for taking out this tumor, Vignesh?
I think one is for surgical debulking. I think the vision on that one eye was still, it was like 20 over, I think 150. So it's still sort of salvageable. One, if you can decompress the optic nerve there and save vision. Two, possibly just sort of reconstruct the anterior, the floor of the anterior fossa. But I think, a big factor in this is going to be try to preserve his vision on that eye.
Right. And what type of craniotomy do you think would be best to access this?
I think like a sort of bifrontal bicoronal cranial with like a subfrontal approach.
Good. Excellent. Yeah, exactly. And as you said, you'd need to do an anterior skull base repair. So several options for that, either a fascial graft or pericranium. And then anytime you're going to have to repair the skull base like that, or when you're going to need good brain relaxation, you can think about a lumbar drain. And that was done in this case.
So this, as you can see below, is positive with neuroendocrine markers, synaptophysin, INSM1, and CD56. And at the top, at the top left, it consists of these nests of, poorly differentiated cells embedded in a fibrous stroma. On the right side, at the top, you see necrosis, the light pink element, as opposed to the left viable tumor in the right upper picture. Okay, so with necrosis in an olfactory neuroblastoma, you are already in a high grade category, and there is some grading suggestions of this tumor. For instance, Hyams grading system, in which necrosis elevates this Hyams grade. There's also a clinical staging called Kaddish stage, where it's based on tumor location, nasal cavity, sinonasal area, beyond the sinonasal area. Maybe you're going to talk about that. But this is a higher grade tumor, positive with synaptophysin and other neural markers. I mean, it kind of is reminiscent of a neuroblastoma of childhood in some ways. Next, enhance the name. You can see here on the left, circled areas represent a high frequency of mitotic figures found in this histology. The Ki67 is high. And importantly, a keratin stain is negative to differentiate this lesion from sinonasal undifferentiated carcinoma, SNOC, and other epithelial tumors in this area that may be in the differential diagnosis, but strong positivity with neuroendocrine markers, negative keratin, and overall morphology is, most suggestive of the esthesio neuroblastoma or a high-grade olfactory neuroblastoma here.
Yeah, and so olfactory neuroblastoma, these is as with any neuroblastoma, the cells are from neural crest origin, and the presentation that we saw here is really pretty typical. There's this bimodal age distribution in the second and fifth and sixth decades, where patients tend to present. There's no predilection for males versus females, and it usually arises from the cells near the cribriform plate, olfactory cells near the cribriform plate, and involves the ethmoid air cells. The 5-year survival of these tumors is actually good, despite how malignant they behave and look. If there's no metastasis and a somewhat localized tumor is completely resected, there's actually, some people describe the size of 90% 5-year survival. And the best survival is accomplished with chemotherapy and radiation. And the standard dosing for that 60 gray and 30 fractions. Some people have also advocated for pre-op radiation, and obviously that limits wound healing, and there's not a lot of evidence for that. I've certainly never seen us do that here. Proton beam also has good control over these tumors, and as Dr. Gultekin mentioned, the Kaddish grading scale is typically used. It's fairly common sense. It just essentially describes whether the tumor is confined to the nasal cavity or how much involvement of the sinuses there are.
Did you look at what the histological grade?
His grade I think was 2, but I would have to check.
3. It was
3.
Mm-hmm.
Okay.
So 3 and 4, unfortunately, is probably around 40, 50, maybe 40% or less 5-year survival. But I just wanted to say that, I mean, this is an aggressive histology.
Yeah, definitely very, very aggressive tumors.
And they can even come back with surprising clinical scenarios like spinal dissemination. I have seen one.
Well, all right. Thank you, Dr. Gultekin. I think that does it for us for Neuropath today.
Thank you very much.
Yeah, we could see it. You had it before.
Oh, okay, hold on. Let me share it again. Can you see it now?
No, not right now. You had it before. Go back and share it again. You have to open up the
Yeah,
PowerPoint.
yeah.
There you go.
Okay, you can see it now.
Yeah, you're good. All right, you ready to go?
So yeah, so this is, I'm gonna be talking about the entry zones and approaches to the brainstem. And so this is just an outline of the talk that we will be doing. So I'll first talk about the historical background of how we got to these brainstem entry zones, and then I'll focus my attention on the different brainstem entry zones of the midbrain, the pons, and the medulla, and I'll divide it up into those three separate sections and talk about the lateral, the ventral, and the dorsal entry zones of each of those three structures. And then I'll focus my attention on discussing the surgical approaches to get to these brainstem entry zones. And so first, to talk about the historical background, initially direct surgical approaches to these brainstem lesions was actually discouraged because there was a reported high mortality rate of about 60% by Bracolo et al. And so then because of this high mortality and morbidity rate, they actually started looking into entry zones to the brainstem. And so this concept started emerging in about 1990s. And since then, at least 20 different entry zones have been identified. And so it's important to note that actually with these entry zones to the midbrain, it's not necessarily a safe entry zone. It's just a region in the brainstem where an incision can be done with acceptable outcomes because there's sparse eloquent structures around it. However, if you do too much retraction, or if you get lost and you don't know where you are, you can still damage the important structures that are next to it. And so the other important thing to note is that the concept of this safe entry zone is actually meaningless when you have a lesion that distorts the anatomy of the brainstem. And so the surgical approach has to be has to take into account the lesion, not just the normal anatomy. And so this figure is just a figure from a paper that looked at the level of evidence of these entry zones. And so I'm not going to go over all the details of the paper, but basically the main point of this figure is to show that with all these 21 different entry zones that were described, only about 4 of them have a credible level of evidence, meaning that there was it was replicated multiple times, about 30 to 60 times, as you see here. And then most of them only have a few case reports that were reported, or just like cadaveric studies and no clinical studies that reported on these entry zones. And so here, this is just an overview of the brainstem entry zones that we're going to talk about. And so I'll first be talking about the midbrain, the pons, and the medulla. And again, I'll separate it into the ventral, lateral, and the dorsal entry zones of each of these three. And so the first thing is the midbrain entry zones. And so there are 2 ventral, 2 lateral, and 3 dorsal midbrain entry zones. And so we'll first talk about the 2 ventral midbrain entry zones. And so the first ventral midbrain entry zone is the interpeduncular zone. And so here you can see in this photo, this is the optic nerve. This is a cerebral peduncle, and this is the pons, and this is the midbrain. And so in here, this is the interpeduncular fossa. And so the reason why this is called the interpeduncular zone is because the incision is made in the interpeduncular fossa, and it's in between the red nucleus and the ocular motor nerve tract here. And so if you go too laterally, even if you're in this entry zone, if you go too laterally, you could hit the red nucleus and cause Parkinson type symptoms. And then if you go too laterally, you could also hit this ocular motor nucleus as well, or sorry, ocular motor nerve fibers as well. And so here in this picture, you see that the superior borders of this entry zone is actually the mammillary bodies, and then the inferior border is this basilar apex and its perforators. And so because of the proximity of this approach to the basilar apex and to the variability of the basilar perforators, it can make this entry zone quite challenging. And so then the second ventral entry zone to the midbrain that we'll be talking about is the anterior mesencephalic zone. And so this is also called the periocular motor zone because it's next to the ocular motor nerve, as you can see right here. And so this is where the incision would be right here in blue. And so if you make an incision, again, if you go to medially, you'll hit the red nucleus and the oculomotor nerve. And if you go to laterally, in here is the cerebellar peduncle, and in the middle 3/5 of the cerebellar peduncle is this corticospinal tract. And so that's what's important as well. And so if you go to laterally, you could hit the corticospinal tract and cause motor weakness. And if you go to laterally and deep, then you could hit this nigrostriatal tract that's right behind it and get Parkinson type symptoms too. And so it's also important to note that the superior and inferior borders of this zone. And so the superior border is the PCA, as you see right here, and then inferior border is the SCA. So now we just talked about the two ventral midbrain entry zones. So now I'm going to focus my attention to the lateral side of the midbrain and talk about the lateral midbrain entry zones. And so there are two of them. And so the first one is the lateral mesencephalic sulcus. And so that one is, if you look at this picture, this is the dorsal midbrain. This is the pons. And so here you see the superior colliculi and the inferior colliculi, and the medial geniculate body, the lateral geniculate body. And here this is called the pontomesencephalic sulcus because it's at the midbrain and pons junction. And so this lateral mesencephalic sulcus goes from this medial geniculate body to this pontomesencephalic sulcus right here. And usually there's a vein called the lateral mesencephalic vein that's actually lying on top of this sulcus. And so the superior borders of this entry zone are the PCA, and then the inferior border is the tentorium and the trochlear nerve. And so this is actually for lesions that are just located laterally in the midbrain in areas that are like this right here. And so what's important to note about this is if you make an incision here, you see that it's in close proximity to all these tracts. So if you go to posteriorly, then you'll hit the medial lemniscus and cause contralateral proprioception and vibration issues. And then if you go to anteriorly, then you'll hit the substantia nigra. And if you go too deep, then you'll hit the red nucleus and the oculomotor nerve tracts. And so this slide is really just to illustrate that angles and the level of entry point matters whenever you're doing the entry zones to the midbrain. And so for example, for this, even though you're going into the lateral mesencephalic entry zone, if you angle your incision 45 degrees forward, then you'll hit the medial lemniscus. But if you angle your incision at a more acute angle and less than 45 degrees, then you'll be into the middle cerebellar peduncle where the corticospinal tracts are. And then if you angle it 90 degrees to this tectal plate, then you'll be at the dorsal midbrain where the red nucleus is. And so that's why angles matter and can alter the trajectory. And so it's something to be aware of when you're doing these surgeries. And so the other point of this slide is to illustrate that the level of entry point also matters. And so depending on how high up you are or how low you are when you make your incision, you'll hit different nuclei. And so if you're at the lower half of the superior colliculus or the upper half of the inferior colliculus, then you'll hit the cranial nerve 3 nerve roots that you see right here. And so this is superior colliculus, and this is the cranial nerve 3 roots. And so if you're at the level of the inferior colliculus and you make your incision, if you have your angle wrong, you could hit the trochlear nucleus instead of the cranial nerve 3 nucleus, which is at the superior collicular level. And so the second entry zone that we'll be talking about in the lateral side of the midbrain is the inferior brachial triangle zone. And so there's actually not been that many cases reporting this. And one paper had only reported that there was 4 cases that's been described in the literature so far. And so we won't be talking very much about this entry zone. And so just very briefly, this is the superior colliculus, this is the inferior colliculus, and this is the brachium of the superior colliculus and the brachium of the inferior colliculus. And so this entry zone is right here. And so you can see that the superior border of this entry zone is actually the caudal margin of the superior, the brachium of the superior colliculus, and inferior border is the trochlear nerve. And then laterally, it's the spinothalamic tract. And so if you go to laterally, then you could cause contralateral pain and temperature sensation loss. And so now we just talked about the lateral midbrain entry zones. And so now I'm going to shift my attention to the posterior aspect of the midbrain and talk about the 3 dorsal midbrain entry zones. And so the dorsal midbrain entry zones are, the first one is the superior collicular zone. And so that is right here. So this is the superior colliculus, the pineal gland, the inferior colliculus, and cranial nerve 4 right here. And so this is the back of the midbrain. And so this is for lesions that are actually dorsal to the aqueduct. So here's the aqueduct right here in green. And then here is usually the area where you would want to use these this entry zone for. And so this incision is actually made between the upper edge of the superior colliculus, right, that you see right here. And then the landmark is actually, the aqueduct is the midline landmark that you want to look for. And so also what's important to note is that the aqueduct actually determines how deep you can go. So if you go deeper than the aqueduct, then you'll hit the oculomotor nucleus. And if you go even deeper than that, then you'll hit the medial longitudinal fasciculus and get an INO. And also it's important to note from medial to lateral, if you go medial and off midline, then you'll hit the central tegmental tract. And if you go to laterally even more, then you'll hit the red nucleus, which is right here. And so the second dorsal entry zone to the midbrain that we'll be talking about is the inferior collicular zone. And so that is location right here. And so this is superior colliculus, this is the inferior colliculus. So this entry zone is actually in between the inferior colliculus and the trochlear nerve. And so it's right here as well. And so this is for lesions that are dorsal to the aqueduct. So this is the aqueduct and this is the area, but here, this is the inferior colliculus. Now we're talking about the inferior collicular area. And earlier we were talking about the superior collicular area. So what's important to note again is that the midline landmark is the aqueduct. And so again, the aqueduct provides, how deep you should go. And so if you go deeper than the aqueduct, then you'll hit the trochlear nerve. And if you go deeper, it'll be the MLF. And then if you go even deeper, it'll be the decusation of the superior cerebellar peduncle. And so you could get cerebellar ataxia if you hit that. And so now the last dorsal entry zone to the midbrain that we'll talk about is the intercollicular region. And so this is the area that's in between the superior and inferior colliculus in the midline. And so this is a region that's supposedly supposed to be safe and sparse in fibers. However, it's only really been reported in 1 or 2 case reports, and only 1 study reported that it had less morbidity than the supracollicular and the infracollicular approach that we just talked about. And so now we just talked about the ventral, lateral, and dorsal midbrain entry zones. So now we're going to move to the Pons, and we'll talk about the lateral and the dorsal entry zones of the Pons. And so the lateral entry zones, there's 3 of them, which are right here. And so the first lateral entry zone to the Pons that we'll talk about is the supratrigeminal zone. And so here you can see the midbrain, the Pons, and the medulla. And so here is the cranial nerve 5, 6, 7, and 8. And so the reason why it's called the supratrigeminal zone is because it's superior to the trigeminal nerve, as you can see right here. And so this is for lesions that are located above the entry zone of cranial nerve 5 right here. And so if you see here, the entry zone is actually that you make is supposed to be parallel to these deep transverse pontine fibers. And if you skive and you're not parallel, then you could hit this corticospinal tract that's anterior. And that's what you see right here. And so it's just important to be aware of, if you go to anteriorly, then you'll hit the corticospinal tract. The next entry zone on the lateral side of the Pons that we're going to be talking about is the peritrigeminal zone. And so the reason why it's called the peritrigeminal zone is because it's around the trigeminal nerve. And so here's the corticospinal tract again right here, and then this is the peritrigeminal zone right here. And so you can see here in blue is the peritrigeminal zone, and here is cranial nerve 5 is the superior border, and the inferior border is cranial nerve 6 and 7. So you can see that right here. And so if you make an incision right here, you can see that if you go too anterior and medially, then you'll hit the corticospinal tract. And if you go too posteriorly, then you'll hit the trigeminal nerve and the motor nucleus of 5 and sensory nucleus of 5. And so it's important to note actually that the mean distance between this corticospinal tract and the trigeminal nerve is actually just very small. It's only 4.6 millimeters. And so, and also the depth that you can dissect until you get down to the motor and sensory nucleus of trigeminal nerve is actually only 11 millimeters. So it's just something to be aware of when you're doing this approach. And so now we'll talk about the last lateral entry zone of the Pons. And so it's called the middle cerebellar peduncle zone, or the lateral pontine zone. And so it's called the middle cerebellar peduncle zone because it's here, this is the middle cerebellar peduncle, and so that's why it's called that. And so this is for lesions that are deep, central, and lateral to the pons, or if they're exophytic lesions. And so the most important thing to note about this is anterior to this zone is this corticospinal tract that's shaded in blue right here. And so now we just talked about the lateral pontine entry zones. Now we're going to talk about the dorsal pontine entry zone. So there's actually 6 of them, but 2 of them, only had had no clinical cases and were only described in cadaveric studies. And so we won't really be talking about those 2 entry zones. We'll be focusing our attention on these 4 right here. And so just a quick overview of the anatomy of the 4th ventricle, just so you can understand why the entry zones are called what they are. And so the first part is that this is the back of the brainstem, and so this is the pons, and then this is the medulla right here. And so here is the rhomboid fossa, or the floor of the 4th ventricle. And so the floor of the 4th ventricle is actually separated into 3 different parts. And so the first part is called the superior part. It's the part highlighted in yellow, and that's the part that's in the pons. And the second part is the intermediate part, and that's the part that's at the pontomedullary junction. And so it's actually corresponds to the superior and inferior borders of the lateral recess, which is right here. And then the inferior part, the third part is called the inferior part, and that's the part that's in the medulla. And so this is the median sulcus, and the median sulcus divides the rhomboid fossa into halves, as you can see right here. And this is the area postrema, the vagotrigone right here, and then right above it, the hypoglossal trigone right here. And so here in yellow is the sulcus limitans. And so what's important about this is that it deepens and forms dimples right here, right next to this bump, and that dimple is called the fovea. And so what's important is that with the fovea, you know that immediately medial to it is the facial colliculus. So as you can see right here. And so the facial colliculus is actually made of the cranial nerve 7 nucleus wrapped with a cranial nerve 6 wrapped around it. And so here you see the superior foveal triangle. And so this is bordered by the sulcus limitans right here. And what's important to note about this is that if you bisect this triangle at the apex, this blue line right here, then it gives you a landmark. It's a landmark for where the top of the facial colliculus is. So you see it right here. So this is cranial nerve 7. This is cranial nerve 6 nerve root. The other thing to note here is on the superior foveal triangle, the superior lateral border where this yellow is actually the important because it's the trigeminal motor and sensory nucleus is right deep to the sulcus limitans right here. And so this is just an overview of the approaches, the entry zones that we'll be talking about in the 4th ventricle. And so the first one that we'll be talking about is the median sulcus of the 4th ventricle. So this is that median sulcus that we talked about earlier. It divides the rhomboid fossa into halves. And so the median sulcus is actually this entry zone in the midline. And even though they say it's a safe entry zone, it's not actually a safe entry zone because right laterally to it is the MLF. And so even if you do slight retraction it could cause damage to the MLF. And so some people don't really like using this entry zone, but it's a entry zone that's been described in the past. And so the second entry zone that we'll be talking about is superior collicular zone. And so that's for lesions that are deep to the floor of the fourth ventricle, superior to the facial colliculus. And so the reason why it's called the superfacial collicular zone is because this is the facial colliculus here. And so the area that's superior to the facial colliculus is called the superfacial collicular zone, which is right here. And so the borders of it, the superior border is the frenulum, and then the inferior border is the facial colliculus right here. And then the medial border is MLF, and the lateral border is this sulcus limitans, and the trigeminal mesencephalic tract, the central tegmental tract, and also right here as well, it's the motor nuclei and sensory nuclei of trigeminal nerve, which is deep to the sulcus limitans right here. And so now we'll talk about the infrafacial collicular zone. And so the reason why it's called the infrafacial collicular zone is because it's underneath the facial colliculus right here. So it's this area shaded in green. And so this is for lesions that are deep to the floor of the fourth ventricle and inferior to the facial colliculus. And so the borders of this entry zone is actually the facial colliculus here. This is cranial nerve 7 nucleus and cranial nerve 6 around it. And then the inferior border is actually this upper part of the hypoglossal trigone and the attachment site of the telochoroidea. And so it's important to note here, just to show that the border, the superior and inferior border of this entry zone is actually corresponds to the lateral recess and that intermediate part of the floor of the fourth ventricle that we talked about earlier.
Yeah, but just quick thing. I think it's the opposite. The facial colliculus, you have the fibers of the facial going around the adducens nucleus. You know what I mean? You have the nucleus is 6 and the facial fibers are going around, elevating and forming the colliculus. But you don't have the 7th nucleus there.
Oh, I see.
Just for the borders.
Oh, my bad. Then the medially is the MLF and laterally is the nucleus ambiguous. And so that's just something to be aware of when you have these entry zones. So then so now the last case that we'll be talking, or the last entry zone that we'll talk about is the superior foveal triangle. And so that's here. And so this is limited by the sulcus limitans. And so the important thing to note here again is the trigeminal motor and sensory nucleus is right here. And then the inferolateral border of the superior foveal triangle is where the entry zone is. And so it's this thing shaded in red. And so this is for lesions that are deep to the pons and located at the level of the facial colliculus. So you see this is at the level of the facial colliculus. But the only caveat is that this is to show that depending on where the lesion is in relation to the facial colliculus, it can push the facial colliculus different ways. And so if the lesion is medial and at the level of the facial colliculus, then it'll push the facial colliculus laterally. And if it's lateral to the facial colliculus, then it's going to push the facial colliculus medially. And so this approach right here, since it's lateral here, it would be better for lesions that displace the medial colliculus, or that displace the facial colliculus medially. And so now we just talked about the Pons entry zones. And so now we're going to move our attention to the medulla and talk about the lateral and the dorsal medulla entry zones. And so just a quick anatomy of the medulla. So this is the front of the medulla, and this is the back of the medulla here. And so the anterior mesencephalic, the anterior median sulcus divides the pyramids, and then the anterior lateral sulcus divides the pyramids from the olives. And then the posterior lateral sulcus divides is right behind the olive. And so on the dorsal surface of the medulla, the midline is divided by the posterior median sulcus. So it divides the fasciculus gracilis. And then the posterior intermediate sulcus, which is sulcus right next to it, divides the fasciculus cuneatus from the fasciculus gracilis right here. And so now we'll talk about the 3 lateral entry zones to the medulla. And so the first one is the olivary zone. So here you can see this is the pyramid, this is the olive, this is the anterolateral sulcus, which is also known as the pre-olivary sulcus because it's anterior to the olive. And here is the post-olivary sulcus because it's posterior to the olive. And so the entry zone here, so you can see that the entry zone is right here. And this is where you would make the incision. And so you can see that if you're too anterior, then you'll hit the pyramids. And if you're too medial, then you'll hit the medial lemniscus and the hypoglossal nerve fibers. And if you're too posterior and lateral, then you'll hit the spinal thalamic tract. And so here it's also important to note that the depth of dissection that you can go is actually only 4.7 to 6.9 millimeters. And the rostral caudal length of the incision is only like 13.5 millimeters. And so the second lateral entry zone that we'll talk about is the anterolateral sulcus. And so it's also known as a pre-olivary sulcus because it's the sulcus that's anterior to the olive, which is right here. And so here you can see that this is cranial nerve 12 roots, and this is cranial nerve 1 root. So in between the cranial nerve 12 and the cranial nerve 1 root is the anterolateral sulcus zone right here. And so this actually also corresponds to the decussation of the pyramid right here. And so because it corresponds, because it's close to the pyramidal tract and so close to the decussation, this is actually preferred for exophytic lesions that are in the anterior lower part of the medulla. And so here, this is the olive, this is the anterolateral sulcus, the posterior lateral sulcus behind the olive. And so here's where you would make the incision. And so anterior, if you go to anterior, you'll hit the pyramids. If you go to medial, you'll hit the hypoglossal nerve and the medial lemniscus again. And so now the third entry zone to the medulla is the lateral medullary zone, which is also called the inferior cerebellar peduncle zone, because this area is actually, you're going through the inferior cerebellar peduncle. And so you make an incision in the inferior cerebellar peduncle, and the incision is supposed to be inferior to cranial nerve 7 and 8, and nuclei, and posterior to the origin of 9 and 10. So this is 7 and 8, 9 and 10. And so now these are the 3. So we just talked about the 3 lateral entry zones to the medulla, and now we're going to move our attention to the back of the medulla and talk about the 3 dorsal entry zones to the medulla. And so here is the back of the medulla. And so the posterior median sulcus is the first one we'll be talking about. It's an incision that's on the medial sulcus. It's on the median sulcus right below the obex. And so it's bordered laterally by the gracile fasciculus. And then the second one is the posterior intermediate sulcus, which is sulcus right next to it. And so that's bordered by the gracile fasciculus and the cuneate fasciculus. And then the third one is the posterior lateral sulcus, which is also known as the post-olivary sulcus or the retroolivary sulcus, which is right here. And so that's bordered by the cuneate fasciculus, and then by the spinal trigeminal tract and nucleus, and deep to it is the nucleus ambiguus. And so another important thing to note is that the distance from here to the nucleus ambiguus is only 4 millimeters. And so just something to be aware of. And so now we just talked about the entry zones of the midbrain, the pons, and the medulla. And so now I'm going to go into the surgical approaches to get to these entry zones. And so the first one is the orbitozygomatic approach. And so here, this is the front of the midbrain. And so this approach really just gets you to the ventral part of the midbrain. So as you can see right here. And so here is another shaded area of the area that you expose with the OZ. And so here's the optic nerve, mammillary bodies, the ocular motor nerve, the interpeduncular fossa, and the cerebral peduncle. And so it's important again to note here that in the middle 3/5 of the cerebral peduncle is the corticospinal tract in blue right here. And so the entry zones that you have access to here is the interpeduncular safe entry zone, and then the anteromesencephalic entry zone, which is right here, also known as the periocular motor entry zone because it's next to the ocular motor nerve. And so here again, the superior border of the interpeduncular zone is the mammillary bodies, then the inferior border is the basilar apex right here. And so for the anterior mesencephalic zone, the superior border is the PCA and the inferior border is the SCA. And so that was, I just talked about the OZ, which was an approach to the ventral part of the midbrain, and now we'll shift over to the lateral part of the midbrain. And so the approach to get there is the subtemporal approach. And so with the subtemporal approach, it's the exposure that you get is shaded in purple right here. And so with the subtemporal approach, you have access to the anterior mesencephalic zone, and then the lateral mesencephalic zone here as well. And then here's just a picture of what it looks like when you go under to do the subtemporal approach. And so this is the temporal lobe, you're retracting the temporal lobe up. And here you see the midbrain right here in cranial nerve 3. And so here's just a blown up view of the same thing. And so this is the anterior mesencephalic zone that you see here. And so if you want an even if you want more of a view of the upper part of the pons, you can do a transtentorial extension, which basically means that you divide the tentorium. And so this gives you a view of just of the midbrain as well as the upper part of the pons. And so here, after you do that, you can see a better view of the lateral mesencephalic zone. And then after the transtentorial extension, you now also have the super trigeminal entry zone that you can access, which is right here. And then if you want to see even more of the pons, the lower part of the pons, then you can do a Kawase, which is also an anterior petrosectomy. And this approach gives you access to the peritrigeminal zone that you see right here. And so now we just talked about the approaches to the lateral side of the midbrain. So now we're going to focus our attention to just the posterior lateral side and how the approaches to get to the posterior lateral side of the midbrain. And so this is an approach, the lateral supracerebellar infratentorial approach. And so here, this is the shaded area is the what you get when you do this exposure and what you can see. And so here's the superior colliculus, this is the inferior colliculus, and this is the trochlear nerve. And here's that lateral mesencephalic sulcus we talked about earlier. And so this is just to show you the view that you get. So here's the sigmoid sinus, and this is the transverse sinus, this is the tentorium, this is the cerebellum. So you're going under the tentorium and over the cerebellum. And here you see cranial nerve 4 right here, which is the same as right here. And then you see the SCA as well. And so here, this is the inferior collicular zone, and that you see right here. And cranial nerve 4, and then the lateral mesencephalic sulcus with the lateral mesencephalic vein running on top of it. And so again, so this is the lateral mesencephalic zone we just talked about, and this is, you can have a straight on view of this lateral mesencephalic zone with this approach, but you can also see the colliculus and the quadrigeminal plate, so you can have access to the supracollicular zone, the intercollicular zone in purple, and the infracollicular zone. And so the important thing to note with this is that here with this approach, you have a direct view and straight on view of this lateral mesencephalic zone, but here you have an oblique view of the quadrigeminal plate. And so now we just talked about the approach to get to the posterior lateral side of the pons. So now we're going to move our attention to the dorsal part of the pons and talk about the approach to get to the dorsal midbrain. Sorry, to the dorsal midbrain. So this is the midline supracerebellar infratentorial approach. And so this is the midbrain, this is the pons, this is the area that you see with the midline supracerebellar infratentorial approach. So here you can see that you have a direct view of the quadrigeminal plate. And so this is also right here is just what you see. You see the vein of Galen, the basal vein of Rosenthal, and the pineal gland. And so here, if you dissect the arachnoid from the pineal gland and push it down, which would be right here, and then here they cut the vein so you can have a better view of the collicular plate. So this is superior colliculus, and this is the inferior colliculus, and this is the tentorium. And so With this view, you still have access to the lateral mesencephalic zone that we talked about earlier. And you also have access to the supraclavicular zone, the interclavicular zone, and the infraclavicular zone. And so the important thing to note here is that with the midline supracerebellar approach compared to the lateral supracerebellar approach, the midline supracerebellar approach, you can have a direct view of the collicular plate in these entry zones and a more oblique view of the lateral mesencephalic sulcus zone. And then with the lateral supracellular infra this is the posterior fossa jugular bulb, the sigmoid sinus, and the semicircular canals are right here. And so this is the sinodural angle. And so it's the angle between the sigmoid sinus and the middle fossa dura. And so what's important to note here is the Troutman's triangle right here shaded in orange. And so it's the bordered anteriorly by the semicircular canals right here and inferiorly by the jugular bulb and posteriorly by the sigmoid sinus right here. And so the importance of this Troutman's triangle is that if you go through here, it gives you access to the posterior fossa through the mastoid. And so after you open this dura here, this is the view that you see. It's just a blown up view. And so you see cranial nerve 5, 8, ICA, and then the middle cerebellar peduncle. And so just a reminder, the corticospinal tract is right here in blue. And so this is the entry zone that you have access to is the supratrigeminal zone. You can also see the peritrigeminal zone right here in yellow. And then the last thing you could see is also the middle cerebellar peduncle zone, which is also the lateral pontine zone. And so this is just to show you the view that you get with the retrosig compared to a subtemporal approach with the Kawase and transtentorial extension. And so with both of them, with the transtentorial extension, you have the view of the supratrigeminal zone, but with the retrolab, you're able to see the peritrigeminal zone. In the Kawase, you can see the peritrigeminal zone, but it's just a little out of view. And then with the retrolab, you can see the lateral pontine zone, but in the Kawase, you can't. And so this is, we'll talk about the retrosig now. And so this is a shaded area that you see, the approach that the exposure that you get when you do the retrosig approach. And so you can see everything from the tentorium down to the lower cranial nerves. And so here is the transverse sinus, this is the pinna, this is the sigmoid sinus, and this is the cerebellum. And so after you dissect through the CP angle, this is the sigmoid sinus, transverse sinus, superior petrosal vein, the cranial nerve 5, this is cranial nerve 7 and 8 in the lower cranial nerves. And so the entry zones that you see are the supratrigeminal zone, the lateral pontine zone, and the lateral medullary zone that we talked about earlier. And here you can see the peritrigeminal zone is actually a little bit outside of this view because it's hard. It's going to be hard in a retrosig to be able to get a more anterior view of the Pons. And so here, this is just a comparison of the view that you get from a retrosig compared to a retrolab. And so with the retrolab, it's actually more time consuming for ENT to drill. However, you get, and you have a more limited exposure and limited view than this retrosig approach. However, you can have a better view of this peritrigeminal zone. And so then with the similarities between these two is with the retrosig, you can see retrosig and retrolab, you can see this supratrigeminal zone, and then in both of them, you can see the lateral pontine zone, and then in the retrosig only, you can see this lateral medullary zone right here, which you can't see in the retrolab. And so now we're going to talk about the approach to get to the fourth ventricle. So this is the this is the fourth ventricle right here. So this is the telovelar approach. And so what you do is after you do your suboccipital craniotomy and the C1 laminectomy right here, you go in between the tonsils and get to
And this is the view that you get. And so this is the retractors holding the tonsils back, and this is the uvula. And so the floor, this right here is actually the roof of the fourth ventricle. It's the inferior part of the roof of the fourth ventricle, and it's made of the inferior medullary velum and the tila choroidea. And so if you make a cut in here in this yellow line through the tila and the inferior medullary velum, you actually, this is the view that you get. You can see the whole rhomboid fossa, and this is the cerebral aqueduct. And so here's just another view of the same thing. So here's a cerebral aqueduct. This is the rhomboid fossa, the median sulcus dividing the dividing the floor of the fourth ventricle. This is the obex, and then this is the facial colliculus and the stria medullaris right here, which is also right here. And so these are the entry zones that you can see in the floor of the fourth ventricle. So you can see the median sulcus, which is in the midline, and that's that entry zone that we talked about. That right laterally to it was the MLF. And so if you retract just even a little bit, you can cause damage to the MLF. And then here's the facial colliculus. And so of course, superior to that is the suprafacial collicular zone, and then inferior to that is the infrafacial collicular zone. And then directly lateral to the facial colliculus is the superior foveal triangle, and the inferior lateral border of the foveal triangle is this the inferior lateral border of the superior foveal triangle is this superior foveal triangle entry zone. And so this again is for lesions that are at the level of the facial colliculus, right here. And so that was the telar-velar approach. And so now this is we'll talk about the suboccipital approach. And so this is the dotted line is the exposure that you get with the suboccip. And so this is just the the craniotomy and the C1 laminectomy, and this is the approach you get. You just don't go thin through the tonsils as you do for the telar-velar approach. And so the entry zones that you have access to is the posterior median sulcus, the posterior intermediate sulcus, and the posterior lateral sulcus, as well as the lateral medullary zone here. And so now we'll talk about the far lateral approach, which gets you access to the lower part of the medulla, as you can see in purple right here. And so here is the suboccipital triangle and the muscles that make up the suboccipital triangle. If you go in through the suboccipital triangle, then you'll see this posterior arch of C1, and then the sulcus arteriosus, which has the V3 segment of the vert running along it. And so after you do your suboccipital craniotomy and the C1 laminectomy, this is the view that you see. And if you need to, you can also drill this part of the transverse foramen, the posterior aspect of the transverse foramen, to mobilize the vertebral artery forward, so you can have a better view. Or you can also drill this 1/3 of the condyle to be able to get a more anterolateral view of the medulla. And so here, this is just the view that you get. This is the blown up view. So this is 9 and 10. This is 11, 12, and then C2 rootlets and C1 rootlets are over here. And so this is the V4 segment of the vertebral artery. And so with this approach, this is the pyramids and this is the olive. So with this far lateral approach, you can see the olivary zone right here. And then you can also see the lateral medullary zone, which is back here. And you can see here that this is the cranial nerve 12 rootlets, and this is cranial C1 rootlets. And so in between that is the anterior lateral sulcus zone. And so this is just a comparison. So you can see what you get when you do a far lateral versus a retrosig approach. And so with both of them, you can see the lateral medullary sulcus or lateral medullary zone. However, in the retrosig, you have access to these entry zones, and then in the far lateral, you have access to the lower part of the medulla. And so this is just a slide of the to summarize all the entry zones that we talked about. We talked about the midbrain entry zones, Pons, and the medulla, and separated into ventral, lateral, and dorsal entry zones. And then this is just a summary of the approaches that we just talked about, separated into like lesion location and by surgical approach.